People will always come in a little bit late, of course, but nobody really wants to hear me. I know everybody's joined to listen to our distinguished speaker today, Dr. Anita Datta. But I'm going to give a little prelude. And before I do, of course, I'd like to acknowledge that we're hosting this event on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And we are very grateful to be able to work, live, and play on their lands. I'm going to give you a little quick overview of the Women's Health Research Cluster. As probably many of you have already seen this slide many times, we do have to update that little infographic at the end. The real reason I'm showing you this is because I think it's really important to have more research on females only. It's great to have sex-different studies, but it's also really important to highlight women's health, and female health is not just how they differ from men and men's health or male health, but how female unique characteristics might drive health disparities, health characteristics and outcomes. And I always like showing this data, showing you that female-only studies are really low. It's like 6% compared to 40% of male-only studies. That's in mice and rats. And with some undergraduate students, this summer, we also looked at human and animal studies from 2009 to 2019. So you can see a 10-year swing there. A lot of studies are now incorporating both sexes, which is fantastic. But look at those female-only studies, very, very small percentage. And you can see now, this is in neuroscience and psychiatry journals. So you can see a little bit lower in those journals themselves. Still very low representation of female-only studies. So certainly important. We want to thank our sponsors, and we also run our Women's Brain Health Virtual Conference that's happening until June, so it's every month. I think the next one is on Friday, if I'm not mistaken. And so please do join us. If you're a trainee, you can, it does cost some money, but there are some awards still available to join for free. For today's conversation, please do follow us on Twitter. If you so desire. You might see me looking at my phone. That's because I'll be tweeting something that Anita said. And there's a Slido for asking questions. Obviously, feel free to join us on Facebook or Twitter at any time. And sorry, this is old. I forgot to update it. You can join us. There's a link on our website that you can join. You don't have to email us anymore. But also, last thing before I introduce Anita, Dr. Datta, I should say, it's the end of November, and November is very well known for men's health, right? Movember. And I donated, my son has a very hairy face. I saw him yesterday. And we don't have anything for women's health. And I really think that we should have something. So I would like us to consider, those of you to consider supporting women's health research. You can do through any charity you so desire, but we also have a tax deductible link on our website, and we would be honored to receive donations, of course. Now, without further ado, I'm going to stop sharing my screen and introduce Dr. And then Dr. Anita Datta can also share her screen while I'm introducing her. Dr. Datta is a pediatric neurologist and epileptologist. Oh, I can't say that. And a clinical associate, she'll say it to you for you, clinical associate professor at BC Children's Hospital. She's a program director of Epilepsy Fellowship Training Program and medical school director for neurology. She obtained her MD from Saskatchewan and her pediatric neurology residency at University of Alberta. She went on to an epilepsy and clinical neurophysiology fellowship at Boston Children's Hospital at Harvard University. I don't know if you've heard of that particular place. She's a board member of the Canadian Association of Child Neurology and the Canadian Board of Registered EEG Technologists. Her primary clinical interest is epilepsy and its surgical management. She's also involved in the tuberous sclerosis.
Yeah.
Obviously, I need to read these ahead of time. Rec Clinic, and is also part of the ketogenic diet team. Her research interests include clinical epilepsy and neuropsychological outcomes. She's involved in several clinical trials for novel and precision therapy for epilepsy, and she's obviously co-authored several peer-reviewed publications and book chapters in this area. And as you may know, I always ask for fun facts from people. And I love Dr. Anita Datta's Fun fact, because one of her biggest accomplishments so far has been that she won the award of Best Bowler of the Year in grade 12. So without further ado, I present you Dr. Anita Datta. Thank you so much.
Thank you. Are you all able to see my screen?
Yes.
Okay, perfect. So today I'm going to be talking, I'm going to basically give a review about special issues for teenage girls and young women with epilepsy. And I have no conflicts of interest. And I wanted to start off by asking, what do these women all have in common? Florence Griffith Joyner, Harriet Tubman, Susan Boyle, Margot Hemingway, Agatha Christie, and Amy Lee. These are all successful women with epilepsy, and probably just the tip of the iceberg. So I'm going to start with a case that I think kind of exemplifies some of the unique issues that women with epilepsy face. This is a patient I've been following for a few years, a 16-year-old female with a history of epilepsy, tuberous sclerosis, mild intellectual impairment. She first started having seizures at 6 years of age, where she would feel scared, followed by head and eye deviation, and sometimes it would go on to a convulsive seizure. And she tried different medications in the past and developed side effects like a rash with carbamazepine, behavioral issues with clobazam. Regarding her seizure frequency, initially they weren't that frequent, 1 to 2 per year. And then at 11 years of age, she had a spike in her seizures. They were weekly, with clusters, particularly around her period. At 12 years of age, she started valproic acid, and they reduced to once every few months. 14 years of age, lamotrigine was added because these two medications work well together, and she had complete seizure control. In addition, she had an anxiety disorder and sees a psychologist regularly. She developed severe acne, which was making her feel down. She gained 15 kilograms over the past 3 years, which was also contributing to her depression. And she noticed that her menstrual cycles were irregular over the past 3 years. In addition, she was sexually active, wanted to start a birth control pill. She was anxious she wouldn't be able to get pregnant when she was older and ready. And she was wondering if she needs to change any of her medications in preparation for that. So there are several unique issues presented in this case. Why did her seizure frequency change at puberty? Why did she notice clusters around her period? What is the significance of the weight gain and acne? Are the irregular periods related to her epilepsy or medications? And what is the best form of contraception for her? Can she get pregnant in the future? And will seizure medications affect the pregnancy? So today I'm going to review the risk of teratogenicity with different seizure medications, talk about drugs to select and those to ideally avoid, talk about vitamin supplementation and bone health, endocrine disorders and the menstrual cycle, and oral contraceptives. So puberty, as we know, is the onset of reproductive life, starting anywhere from 7 to 14 years of age. And we know that there can be changes in epilepsy. Certain epilepsies may remit, like childhood absence epilepsy, while others may arise, like juvenile myoclonic epilepsy. There can be changes in seizure medication pharmacokinetics, with new hormones, changes in weight, height, as well as compliance and seizure-provoking behaviors. Kids may stay up later, may try alcohol or vaping for the first time. These are some really interesting facts I came across when I was doing my literature review. Did you guys know that sterilization of people with epilepsy was legal in parts of the United States until the second half of the 20th century? Until 1980, some states still had laws forbidding people with epilepsy from marrying. And even today, many women with epilepsy still receive explicit or implicit messages that they should not consider pregnancy. So it goes to show how the stigma of epilepsy affects so many areas of their lives, including their reproductive lives. So for clinicians, we must realize that prepartum counseling should start no later than the prescription of the first anti-seizure medication to a girl or woman of childbearing age. Because 50% of pregnancies in women with epilepsy are unplanned, and many feel that physicians never talk about these issues. In fact, in one study, it showed that 30% say they have never discussed these topics with their physicians. And we know that people with epilepsy often can have memory issues, cognitive issues, so these discussions need to be had repetitively. So let's first of all talk about teratogenicity with seizure medications. So, women with epilepsy are usually unable to stop taking their anti-seizure medications because of the increased risk of seizures, which can lead to loss of job, driving privileges, risk of cognitive decline if they're having uncontrolled seizures. But at the same time, they have to weigh this with the risk of congenital malformations with anti-seizure medications. So, do women with epilepsy choose to have children less often? Indeed, 30% of women do not consider having children because of their epilepsy. But women should only stop their seizure medications for the usual reasons that we would stop it. They have been seizure free for 2 or more years. They accept the risk of having seizures or the risk of recurrence, and they're willing to wait several months, ideally before attempting pregnancy. Now, we know that seizures in pregnancy can have risks for the fetus as well as the mother. Overall, it seems like the fetus is relatively resistant to the effects of seizures, although anecdotal evidence suggests that tonic-clonic seizures may cause fetal bradycardia or miscarriage, but really definitive data is lacking. There is no evidence that simple partial, complex partial, or absence or myoclonic seizures are harmful to the fetus. But likewise, prospective studies have not shown an association between tonic-clonic seizures and malformations. There are certain drugs like topiramate or zonisamide that have been shown to lead to small for gestational age babies. And one prospective study, the URAP study, included a huge volume of patients, and 36 had status epilepticus, and they found no increased risk of maternal death or stillbirth. So I guess we need more information on this area for the fetus. But we also know there are maternal risks. The death rate during pregnancy in women with epilepsy is increased tenfold, primarily due to seizures and sudden unexplained death in epilepsy or SUDEP. And trauma is a leading cause of non-obstetrical cause of death in pregnant women with epilepsy. So one may choose to switch to another drug with more expected safety profile, but ideally this is done long before conception because we know the risk of malformations is highest in the first trimester, the first 8 to 10 weeks of pregnancy, so very early on, and the woman may not even know she's pregnant. Also, it is not well known how the woman may respond to a new anti-seizure medication regarding side effect or efficacy. So let's talk about major malformations. These are defined as structural abnormalities of surgical, functional, or cosmetic significance. And as you can see here, in the general population, the risk is 1 to 3%. With one seizure medication, the risk is about 4 to 9%. And with polytherapy, the risk is up to 8.6%. So overall, there's a 2 to 3 times higher rate than the general population of major malformations, or a 90% chance the child will be normal. There are different profiles with different seizure medications, as you can see here. For example, phenytoin is associated with more cardiac defects or genitourinary defects, phenobarbital with more cardiac defects, valproic acid with more neural tube defects, and carbamazepine with more cardiac defects. This is just another way of looking at it, but cardiac mainly seen with carbamazepine, lamotrigine, barbiturates, cardiac and hypospadias with phenytoin, and again, neural tube defects predominantly with valproic acid. Fortunately, we do not see these as often anymore because of better prenatal care, but fetal valproic acid syndrome is associated with tall forehead, medial eyebrow deficiency, flat nasal bridge, broad nasal root, shallow philtrum, long upper lip, and thin vermilion border. Neural tube defects such as myelomeningocele, which is common with valproic acid, and also fetal hydantoin syndrome, which was found in 11% of those exposed, associated with pre- and postnatal growth deficiency, dysmorphic features, intellectual impairment. Now, pregnancy registries have been extremely important, and these have been done in numerous different sites, as you can see over here, and they have looked at kind of the long-term outcomes of seizure medications and the impact on the fetus and the mother. And different registries have different results, probably looking at different outcome measures, different populations. But as you can see here, they kind of summarize the rates of malformations. And with carbamazepine, it's variable from 2.6% to 5.6%. Gabapentin, 0 to 3.2%, relatively low. Lamotrigine, 2 to 4.6%. Oxcarbazepine, 1.8 to 5.9%. Phenobarb has a wide range, 0 to 14%. Phenytoin, 2.4 to 6.7%. Topiramate, 2.4 to 7.7%. And valproic acid, again, a large range, 4.7 all the way up to 13.8%. Now, in addition to just the seizure medication, we know that dose can have an effect. And one of the studies, the International Registry of Anti-Epileptic Drugs and Pregnancy, or the URAP study, found a direct correlation between dose at the time of conception and the risk of malformations with carbamazepine, lamotrigine, phenobarb, and valproic acid. And as you can see here with valproic acid, a dose less than 740 milligrams per day was associated with a 5.6% risk of malformation. But if the dose was greater than 1,500 milligrams per day, the risk jumped to 24.6%. So really, further research is also required, not only for serum concentrations, but levels as opposed to just the actual dose to predict outcome. Another issue is one drug versus multiple drugs, and previously was thought we must avoid polypharmacy at all costs, because it showed that the risk of malformation with one drug was 2 to 7%, but those on polypharmacy, it was 6 to 18%. However, the North American Drug Pregnancy Registry, or NAPR, suggested that polypharmacy, specifically with valproic acid, drove up those numbers. And malformation rates with carbamazepine or lamotrigine combined with drug other than valproic acid actually had similar rates as either drug in monotherapy. This is another issue that is often overlooked, but it's cognitive teratogenesis. And I'm going to refer to two studies, the neurodevelopmental effects of anti-epileptic drugs, or the NEED study, and the Liverpool and Manchester Neurodevelopmental Group, or LMNG. So exposure to valproic acid has been associated with a decrease in full-scale IQ by 10 points compared to other seizure medications. And this is dose-related. As you can see here, this is the average IQ. And as a dose increases, the lower IQ rates increase. Now, the NEED study did not have a control group, but they found that the full-scale IQ was similar with lamotrigine, phenytoin, and carbamazepine, and as expected, related to maternal IQ. The LMNG study found that full-scale IQ with lamotrigine and carbamazepine was similar to the control group. With carbamazepine, there was a higher risk of IQ less than 85 and lower verbal abilities. And with levetiracetam at 3 years, there was similarity to controls, and it was found to be better than valproic acid. This is summarizing 22 prospective cohort studies and 6 registry-based studies, but IQ of children exposed to valproic acid was lower than controls, and it was 8.69 points less than carbamazepine, 10.8 points less than lamotrigine, 9.25 points less than phenytoin. And the magnitude of these results was thought to be sufficient to affect educational and occupational outcomes later in life. Now, the LMNG study found an association between anti-seizure medications and other neurodevelopmental disorders as well, such as Asperger's, ADHD, autism spectrum disorder, and dyspraxia. And again, it was more frequent in the children of women with epilepsy, 7.46% versus 1.8% in the controls, and specifically statistically significant with valproic acid. In a population-based study, the risks of a formal diagnosis of autism and autism spectrum disorder with valproic acid exposure were 2.5% and 4.4% respectively, compared to 0.5% and 1.5% in the general population. Now, one mechanism for these cognitive changes may be related to apoptosis, or spontaneous cell or neuronal death. And apoptosis has been demonstrated in rat pups with diazepam, phenobarbital, phenytoin, and valproic acid. Carbamazepine, lamotrigine, levetiracetam, topiramate show no apoptosis when given alone. And levetiracetam is the only seizure medicine that does not enhance apoptosis when given with a seizure medication that does induce apoptosis. Maybe why we see a more favorable profile with levetiracetam. So the bottom line is that valproic acid is consistently associated with the highest rates of major congenital malformations, from 4.7 to 13.8%. Lamotrigine and carbamazepine have low malformation rates. Levetiracetam is promising. We need more studies. Phenytoin, phenobarb, and topiramate likely have an intermediate risk. And there's a lot of neuroseizure medications that we just don't have enough information yet to stratify. But ideally, we need to identify the minimum therapeutic dose and level to control the seizures. And this was confirmed by the American Academy of Neurology and American Epilepsy Society that, if possible, avoid valproic acid. Let's move on to vitamin supplementation and bone health considerations. So first of all, folic acid. This is a bit of an area of controversy. We do know that several anti-seizure medications have been associated with lower serum folic acid levels, and low first trimester serum folic acid levels have been correlated with an increased risk of congenital malformations in women with epilepsy. But little direct evidence actually exists that folic acid reduces the risk of major congenital malformations in women taking anti-seizure medications. But the American Academy of Neurology says that many of these studies did not have enough power or were underpowered to detect a benefit. And it is recommended that women with epilepsy should be supplemented with 0.4 to 4 milligrams per day of folic acid before conception. And usually we give a 5 milligram because it comes in a 5 milligram tablet. It's interesting that there was a study by Garcia which found that women taking higher doses of folic acid, greater than 5 milligrams, actually had children with greater psychomotor delay. So having too much folic acid is not necessarily a good thing either. And the NEED study, which did not have controls, they did find that women taking folic acid had kids with higher IQ compared to those that did not take folic acid. And they looked at folic acid pre and periconceptually. Regarding vitamin K, third trimester vitamin K has been suggested for women taking enzyme-inducing anti-seizure medications because of the thought of an increased risk of intracranial neonatal hemorrhage in early case studies. But an epidemiologic study of 662 women with epilepsy with enzyme-inducing agents in pregnancy found no significant difference in bleeding complications of newborns and controls when all of them received vitamin K at birth. So the consensus now is there's insufficient evidence to recommend for or against vitamin K supplementation. Of course, if a woman is anxious, she's on enzyme-inducing agents, we will still give vitamin K. Bone health is another really important issue for women and people with epilepsy. Regarding osteopenia, osteoporosis, anti-seizure medications definitely can contribute. And it's been shown that there's increased rates at multiple sites, including the hip and lumbar spine. And osteomalacia, which is increased osteoid or unmineralized bone, has also been found. However, we need further studies. Most have looked at those that are institutionalized, confounded by poor diet, inadequate sunlight, limited exercise. This is just showing the percentages of osteopenia and osteoporosis of the femoral neck. And green is as expected, and blue is women and men with epilepsy. And as you can see here, people with epilepsy have lower density and higher rates of osteoporosis and osteopenia. And this is further amplified in people that are greater than 50 years of age. Seizure medications can have an impact. Phenobarbital, primidone, and phenytoin are associated with bone loss and fractures, as well as carbamazepine and valproic acid. Lamotrigine is not. And again, there's limited information on a lot of the newer seizure medications. But we know that being on medications for a longer duration or polytherapy can also increase the risk. So we always are telling our patients, exercise, have a well-balanced diet, make sure they have calcium or consider supplementation. Vitamin D is extremely important, and we recommend most kids to take a supplement, as well as avoiding smoking, limiting alcohol consumption. And in those that are at higher risk, for example, those that are immobile or wheelchair bound, we recommend even DEXA scans as screening measures. Let's shift gears and now talk about endocrine disorders and menstrual cycle considerations in epilepsy. So first of all, hormones do impact epilepsy. Estrogen may be proconvulsant. It can reduce inhibition at the GABA A receptor. It alters mRNA for glutamic acid decarboxylase and inhibits GABA synthesis. On the flip side, progesterone may be an anticonvulsant. It increases inhibition at the GABA A receptor, attenuates excitation of glutamate in the hippocampus, and alters mRNA for glutamic acid decarboxylase and increases GABA synthesis. So these are two fighting forces. Menstrual irregularities are common in women with epilepsy, found in about 30%, compared to 12 to 14% in the general population. And with decreased ovulatory rates, they can occur from 75 to 50% with abnormal cycles. There are different types of endocrine reproductive abnormalities that have been identified in women with epilepsy, such as polycystic ovarian syndrome, hypothalamic amenorrhea, premature ovarian failure, and functional hyperprolactinemia. And it's so important to recognize this, especially for clinicians when we're taking that history, that we don't miss these features because these can have long-term serious repercussions regarding fertility. Polycystic ovarian syndrome usually consists of two of the three criteria: multiple cysts in the ovaries, high male hormone levels, excessive facial hair and acne, obesity, irregular menstrual periods, and more frequent anovulatory cycles. And this is found in about 10 to 20% of women with epilepsy, compared to about 5 to 6% of women in the general population. Another entity is hypothalamic amenorrhea, found in about 12% of 50 women with temporal lobe epilepsy in one study, compared to 1.5% in the general population. And it's related to disturbed secretion of pituitary gonadotropins and low luteinizing hormone. And this can lead to amenorrhea, infertility, without the hyperandrogenemia that you see with polycystic ovarian syndrome. Another one that we must be aware of is functional hyperprolactinemia. Again, it's been found to have increased prevalence in women with epilepsy, and it has been demonstrated that generalized and temporal lobe seizures lead to prolactin elevation. And interesting, even the interictal discharges or spikes that we see on an EEG has been shown to increase prolactin levels. And this can lead to polymenorrhea, oligomenorrhea, amenorrhea, subfertility, galactorrhea, and hirsutism. So why is there an increased risk of these reproductive abnormalities? Well, there are several reasons. One thing we know is the brain and seizures, there's a network of hyperexcitability. For example, generalized seizures often involve the hypothalamic relay and may involve, the hypothalamic pituitary relay, leading to some dysfunction with the central glands and hormone release. Seizure medications can have a direct impact on glands. Valproic acid has been shown to increase testosterone to estradiol levels in porcine ovarian follicles. And long-term valproic acid increased the number of follicular cysts and altered sex steroid hormone levels in rats. Seizure medications can also affect the metabolism of hormones. The enzyme inducers increase production of sex hormone binding globulins, and so they actually lower the sex hormone serum concentrations, so lower testosterone and estrogen levels. While the enzyme inhibitors, these will have the opposite effect. And so there can be increased serum androgen concentrations, or women with valproic acid have been shown to have higher estrogen testosterone levels. Also, certain seizure medications can be associated with weight gain, such as valproic acid, carbamazepine, vigabatrin, gabapentin. And this can lead to secondary reduction in insulin sensitivity and promote things like PCOS or polycystic ovarian syndrome. And this could be enhanced by inhibitors such as valproic acid and masked by inducers. Now I'm going to talk about oral contraceptives and seizure medications. So this is also a very important topic that we always must discuss with women with epilepsy because they may not know this. But seizure medications can decrease the efficacy of the birth control pill, which can lead to birth control failure and unplanned pregnancy. And on the other side, some may have increased seizures with the birth control pill. Here is a list of seizure medications that do not have OCP interactions. As you can see, there's a long list that we must know, such as clonazepam, ethosuximide, gabapentin, lacosamide, levetiracetam, vigabatrin, just to name a few. However, it's the enzyme inducers that we must be careful of, because these can decrease the effectiveness of the birth control pill, such as carbamazepine family, clobazam, phenobarbital, phenytoin, rufinamide, perampanel. And if women take these medications and go on the pill, there can be an unplanned pregnancy. Lamotrigine is unique in the sense that women that go on the pill will actually lower the levels of lamotrigine, sometimes up to 50 to 60%. So if a woman goes on the pill on lamotrigine, she may start having more seizures and not know why. And there's a lesser effect with valproic acid and topiramate. Overall, we know that the IUD is the most reliable form of contraception in a woman of childbearing age. And it's reliable, the copper and the levonorgestrel releasing IUD, with relatively lower rates of pregnancy. There are other forms of contraception, but they are not as effective, and there's higher rates of pregnancy involved. And these can also impact the hormones can impact the drugs and vice versa. Catamenial seizures is another important area in women with epilepsy, or unique area. It comes from the Greek word katamenios, meaning monthly. And this is a pattern of increased seizures at specific times in the menstrual cycle that are characterized usually when there's an increased estrogen to progesterone ratio. And this is more common than we realize. At first, people thought that, oh, catamenial epilepsy is just having more seizures just around the time of your menstrual flow. But there are different patterns, as I will show you. And about 30 to 50% have epileptic patterns that correspond to the menstrual cycle. And often we don't realize this until women chart it in a diary and realize that, oh, yeah, there's actually a trend. And the vulnerability to seizures is highest just before and during flow and at ovulation. Now, there are three main patterns that you can see here. Just to remind you guys, day 1 is the first day of menstrual flow, and day -14 is the day of ovulation. And the first graph A kind of is showing those with normal ovulation, while graph B is showing those that often have an anovulatory cycle. And the C1 pattern is associated with exacerbation of seizures in the perimenstrual phase, so day -3 to day +3 of the next cycle. While C2 is associated with exacerbation of seizures in the periovulatory phase, or day +10 to -13. And C3, the luteal pattern, often associated with an anovulatory cycle, is associated with exacerbation during the luteal phase, or day +10 to +3 of the next cycle. So again, we must be aware that these different patterns exist. For treatment of catamenial epilepsy, we know that there is no unique treatment option that has been proven to be more beneficial than standard therapy, meaning the maintenance anti-seizure medications that are appropriate for the woman's seizure type. Consider epilepsy surgery if appropriate. Hormonal therapies should never be offered as first-line therapy. Now, there have been numerous small studies, you can see with small n sample sizes, that have looked at alternative treatments besides the maintenance medications. LIM did a study with acetazolamide in a small number and found a greater than 50% reduction in seizures and 40%. Similarly, some have looked at hormonal treatments and have found some response rates. I find in practice that if I'm working with maintenance medication, I'm not getting response, sometimes I will use acetazolamide or clobazam when the woman is noting an exacerbation in her cycle, maybe a few days before, and then they can stop it a few days after. So in conclusion, the conversation about epilepsy needs to start when we're prescribing that first medication to a young girl of childbearing age, even though they are far away maybe from having their pregnancy. We know that most women need anti-seizure medications during pregnancy, and ideally we have to identify the minimum dose and level to control seizures. Across the board, we know that valproic acid is associated with the highest rates of major congenital malformations and cognitive teratogenesis. Polytherapy regimens that do not include valproic acid may not increase teratogenic risks. It's very important to counsel early, actually, regarding folic acid and bone health. Hormones affect seizures, seizure medications affect hormones. Menstrual irregularities and reproductive endocrine disorders are common. Catamenial epilepsy is common. Knowledge of oral contraceptives is really important. And the IUD is effective and ideally the best form of contraception in young women. So thank you all.
Hi, sorry, these are always so hard on Zoom because you can't hear the audience clapping. So I encourage those of you that wish to do so to please use the clapping feature and your reactions. And because of an early episode with Zoom bombing, we ended up taking off chat features and things. So please put your questions on Slido, which is 15403. Should be in your invitation if you so desire. So I always feel bad about this, but because of our early issues, that's what happens. So unfortunately, everybody gets to hear my voice, which is and the speaker's voice, which is not always the best, I know. But so I have some questions before some show up on the Slido. I guess okay, I'll start with the last one. So is it catamenial epilepsy?
Yeah.
So why? So it was really interesting. I didn't know about the 3 different patterns. But why not? Why is hormone therapy not advised if it is so triggered in a monthly pattern? It seems like that might not be the worst thing to do, or to maybe flatten that curve, so to speak. Or is it because of the 3 different patterns? Is that what's going on? Might be okay for some but not for others? Or
Yeah, I mean, first of all, there's been such, limited information in that area where, like, as you saw, the ends of the studies are really small, and I think we need more information. But also, like, just the success rate, we know that if we can modify the baseline anti-seizure medication, usually we're able to control the catamenial epilepsy for the most cases. And then with the hormone therapy, it would have to be, quite documented that when you're going to initiate that and stop that, because we don't necessarily also want to stop the menstrual cycle, or we don't want to, have that impact as well, right? And with these hormone therapies also having the interactions with the anti-seizure medications, if we can avoid that, all the better.
right.
Yeah.
Okay. And I always find this really fascinating that seizures, so the sort of seizure hormone medication link. And so what I wrote down is what comes first. So and you I think you spoke a little bit about this, but is there any sort of consensus, and or do we just not know enough about? So I know it seems like seizures can cause hormonal imbalances, but also the hormonal imbalances could maybe trigger seizures, and then the medications on top of that can influence hormones. So
Yeah, I think it's, this combination of all, but we know that, there are certain medications that have more of an impact. For example, if, you put a young girl on valproic acid, we know valproic acid can twofold, right? It can cause increased weight gain, insulin insensitivity, as well as it is an inhibitor, so it can reduce or it can increase the sex hormone levels and increase the risk of PCOS. So that may be a reason why in a young girl, I would not even want to use that medication, even if she's far from the childbearing age. Um, the reproductive disorders with women with epilepsy. I mean, most women with epilepsy are able to get pregnant and have normal pregnancies, and we need to screen for these other reproductive abnormalities. But I think the choice of drugs we use really has a big impact.
mm-hmm. Yeah, clearly I thought that was really interesting. So we have a question on Slido that I'll read out. So it's not just me and my questions.
Okay.
If AEDs, your anti-epileptic medications, are stopped prior to pregnancy, is there evidence of any fetal developmental issues if the mother is exposed to drugs at any other point in her life? I had something similar about that. So I know you warned against taking women off of their medications anyway, but I wonder if you can speak to
Yeah,
that.
I mean, if the woman was on, say, valproic acid like 2 years prior, a year prior, it doesn't necessarily mean that that's going to have an impact on the fetus. It's when the woman is on it during the first trimester, specifically the 8 to 10 weeks of the first trimester, where it can have an impact. So regarding, coming off seizure medications before, I mean, usually we're planning this in advance. And I'm even talking to 13, 14-year-olds. Look, I know you're on valproic acid. In the future, we're going to have to try to come off of this or try to change it even now, right? So we're not at that issue down the road. Because ideally, we don't want to make changes or come off meds just because of the pregnancy itself. Um, Sometimes what I do is if I have a girl on valproic acid, I may put her, and if that's the only medicine she's ever responded to, I may put her on a lower dose of valproic acid and add something else like lamotrigine. We know polytherapy is not necessarily worse, and that may help with better control. We also know that valproic acid can have dose dependent effects.
Right. Yeah,
Just
that
so
was
you
pretty
also,
cool.
yeah, and
Yeah.
the other thing I wanted to mention, I commented that, we know have evidence that generalized tonic-clonic seizures can impact the fetus, but there's no evidence that, say, absence seizures, focal impair-aware seizures, myoclonic seizures are going to impact the fetus. So if a woman is just having absence epilepsy and chooses for during that time she maybe wants to lower her dose or come off, we don't have good evidence to say that those seizures are going to necessarily impact the fetus. But there are other consequences with driving, cognition, etc.
Mm-hmm. Oh, and that was one of my questions too, was not about that, but about whether there were different trimesters that might be more sensitive to some fetal developmental issues.
Yeah. So it's
Uh,
definitely the first trimester. I talked about the NEED and LMNG study, and what's interesting too is the NEED study found that women that were taking folic acid, they studied women that were taking folic acid prior to conception and then in the first trimester, and they found that folic acid, women on folic acid, their children had a higher IQ than those that didn't. The LMNG study did not find this, but they only looked at women taking folic acid in the first trimester and not periconceptually. So that's also an interesting difference as well.
right. Right.
Yeah.
Yeah. So, I mean, at the end of the day, it seems like, I know this is probably an unfair comment, but I think it's an appropriate comment, which is, we need more research, right? Like, it just doesn't seem like there's enough evidence out there to definitively say one way or the other. And is it partly because of the, worry about using women that are pregnant or in childbearing years for these sort of clinical studies? Do you think that's contributing to some of our lack of knowledge? I mean, maybe not
Possibly.
specific.
I mean, we don't want to experiment with a very
Right,
susceptible group, right?
right,
But I think it's also really fascinating when I showed the list of all those registries, right? I mean, there's so
right.
many
There's
drug
so many.
registries with
Yeah,
large
yeah,
populations, but
yeah,
they're so variable, right? Because
yeah.
they're looking at,
Right.
different outcomes or different measures. Like,
So different doses too.
yeah, so
Like,
you're seeing risk of
yeah,
teratogenicity from 0 to like 14%.
right, right. I noticed that. Yeah,
Yeah, so I think that's interesting where, maybe collectively, maybe there's some, clearer goals that everybody has or measures.
yeah. What about like, and also, maybe I'll just give one more question to you, and then let you off.
Okay.
What also struck me about the three different phases, or not phases, but characteristics of catamenial epilepsy, right? So that you can have seizures at actually kind of very different times, right? That are
Hmm.
associated with your high E to P, but also low E to P, right? So part of me is sort of thinking, well, so do we know what percentage are in each of those different phases, or can you be in different phases, one person
Yeah,
be in different phases? And
the,
then is there any evidence that there's less seizures during pregnancy? Like multiple sclerosis, you see less symptomology, but I don't know about epilepsy.
so definitely the C1 or the perimenstrual is the most common form of
Okay.
catamenial epilepsy, by far the most common.
Right.
The C2 is the second most common, the periovulatory.
Right.
And the C3 is less common, more common though in women with, say, PCOS, or if they're definitely having, irregular periods. You got to wonder about that, right? Because that's the
Right.
anovulatory one.
Right. Right.
So that's why I still get girls to track it down until they, just so we get an idea. Some may say, oh, I think I have it, but we don't know for sure unless they track
Right.
it.
Right.
Regarding seizures and pregnancy, that's interesting because, first of all, we know that 30% will have a worsening of seizures during pregnancy.
Mm-hmm.
So not by far the most, right?
Right.
Most will actually kind of stay the same.
Mm-hmm.
Some argue that 30% may get better. And in fact, those with a history of
Oh,
catamenial epilepsy may do better in pregnancy with regarding
right.
seizures.
Right.
It's been shown that if you've been seizure-free for the 9 months preceding your pregnancy, you're likely going to continue to do well in your pregnancy.
Oh,
So
okay.
that's a good predictor.
That's
Um,
great.
Another thing that people have looked at for risk of seizures in pregnancy is the drug somebody's on. So even though we often prescribe things like lamotrigine or trileptal, they're thought to be safer in pregnancy. Studies have shown that those have been associated with a higher seizure rate in pregnancy. But I bet you one of the reasons is because lamotrigine and trileptal, they're strongly impacted by estrogen, and they're broken down by glucuronidation. So in pregnancy, women
Right,
have more estrogen, they're breaking
right,
down these drugs, and so the levels
right,
of lamotrigine and estrogen drop. And so often we're having to push up these doses of lamotrigine
right.
and estrogen. So I wonder if in those studies, it's because those levels
The
fell and maybe they
guidance.
weren't adjusted, right?
Right, right.
Yeah, so those are
Yes.
some.
Yeah, that's so interesting. And I was thinking, as you were talking too, well, of course, during pregnancy, those estrogens are really increasing. I mean, they're dramatically higher. And so if that's what's contributing to that pro-convulsive state, you'd expect to see more seizures, but, that doesn't uniformly happen, which is really, really fascinating.
Yeah. Those with focal seizures also thought to maybe have more exacerbation in pregnancy than those with generalized, but again, those are
That's
some
interesting
things.
too. Yeah,
But one thing with the say lamotrigine and trileptal, like we're always pushing those doses up. So pregnant women, we're doing levels every week.
yeah,
We're pushing those doses up to sometimes double of what they were on before.
right,
But we also must remember that after they give birth, those levels are going to normalize quickly,
right.
right?
Very
Within the first
quickly.
3 weeks.
Yeah,
And
right.
so we got to give them a weaning schedule off, or they're going to
Right.
become toxic after.
Right.
Yeah.
Absolutely. Okay, one more question from the audience, and then we'll let you go. But really fascinating, clearly, really fascinating talk, and I hope discussion for everybody. So the question is, could you comment on the possible challenges with epilepsy, related medications, and hormone therapy during the menopause transition?
Yeah, so as a pediatric neurologist, I can't say I know a lot about
Yeah.
that age group, but menopause is obviously another area where, I mean, bone health is a significant issue, and women with epilepsy are known to have a higher risk of what we call premature menopause as well,
Mhm.
where often in their 40s or mid 40s they can already present with premature menopause. So that's something to consider. Like I say, the bone health, we need to counsel about that because as there's changes in these hormones, they can have further decline in their bone health and fractures. Um, but I'm sorry, I can't comment further. It's just not an area that I see as much of.
Yeah. No, that's really, really fascinating. And I'm going to do my own little reactions here again. I just want to have everyone join me in thanking Dr. Anita Datta for a fantastic talk, and really great to hear about epilepsy in adolescents and women. So thank you so much. That was really fantastic.
No, thank you. This has been so fun.